Welcome back to the deep dive. Today we're getting specific, really specific, about a critical area in trauma coding. CPT codes 2100 through 2103. These deal with wound exploration after trauma, and our mission today is to, well, really unpack them. We want to get the exact guidelines, how they're defined, when they apply, and maybe most importantly, when other codes actually take over. It's about understanding that fine line between assessment and major surgery.
Absolutely. And we have to start with the absolute baseline context here. These codes, 2100 to 2103, they are only for penetrating trauma.
Okay.
Think gunshot wounds, stab wounds, that kind of injury. If it's blunt trauma or, just a simple cut that doesn't need deep exploration, these codes are off the table right from the start.
Right, so penetrating trauma is the key. But let's say a patient has that kind of wound. What makes the difference between, say, just cleaning it and stitching it up versus using one of these specific exploration codes? What is wound exploration in this sense?
Yeah, that's the core question. The difference is really about the surgical intent and the depth involved. Codes 2100 to 2103 aren't just about cleaning. They describe procedures focused on surgical exploration, and this is the crucial part, extension of dissection.
Extension of dissection. Okay, that sounds important.
It is. That phrase is really what you need to see documented. The main goal isn't just surface repair. It's about actively exploring deeper to figure out the exact depth of penetration, trying to trace where that bullet or knife actually went.
So it's an investigative surgery almost.
In a way, yes. And what makes coding tricky here is that these aren't just exploration codes. They actually bundle several related procedures together. It's sort of an assessment and initial damage control package, all under one code.
Ah, okay, bundling. Always important to know what's included so you don't bill things separately when you shouldn't. So what exactly is included in that 2100 to 2103 package?
Right, so it includes the surgical exploration itself, obviously, and often enlarging the wound a bit just to see better.
Makes sense.
Then there's the necessary cleanup, like a debridement, getting rid of damaged tissue. And also removing foreign bodies, things like bullet fragments, bits of debris, that sort of thing.
So wait, if the main reason for the exploration is to find and remove a foreign body, like a bullet fragment, you don't bill for the removal separately.
Correct. That's bundled in.
Yeah.
The CPT system sees the exploration and the retrieval of what you find during that exploration as part of the same core procedure defined by 2100, 2103.
Okay, exploration, enlargement, debridement, foreign body removal. Anything else?
Yes, and this is a really critical point. The ligation or coagulation of minor subcutaneous and/or muscular blood vessels.
Okay, hold on. Minor. That word sounds like it could cause some headaches. How is minor defined here?
Yeah.
Because controlling bleeding seems pretty central to trauma care.
It is, and that word minor is, let's say, very significant. It's the boundary.
Right.
Using these codes means you're confirming you only dealt with bleeding from smaller vessels in the subcutaneous tissue or the muscle layer itself, the layers directly involved in the wound track.
So not major arteries or veins.
Exactly. If you have to repair a named major vessel, that's a completely different scenario. That becomes a specific vascular repair procedure, probably with a much higher value code. These 2100 codes are strictly for exploring the path down to the muscle layer, maybe including the fascia, and handling only that localized, non-critical bleeding along the way.
Got it. That clarifies the scope. So the exploration stops, effectively, before hitting major structures or vessels requiring significant repair.
Precisely. That distinction sets up the whole decision tree for coding these encounters.
Now, you mentioned these codes are location-specific. The CPT system breaks them down by body area, right? Even if the basic procedure, that extension of dissection, is similar.
That's right. And it makes sense when you think about it. Exploring a wound in the neck, for example, has very different potential complications airway, major vessels, compared to exploring one in the leg. The anatomy dictates the risk.
So the codes reflect that different risk profile.
Essentially, yes. The CPT gives us 4 specific codes under the umbrella of exploration of penetrating wound. Separate procedure.
Okay, let's walk through them.
We start with 2100, that's for the neck. Then 2101 covers the chest.
Chest wall specifically, right?
Yes, the chest wall. Then there's 2102, which is actually a larger zone. It covers the abdomen, the flank, and the back.
Interesting that those 3 are grouped. Abdomen, flank, back, all under 2102. Why bundle those?
It seems to be because the primary underlying concern in all those areas is often the same. Did the penetration breach the abdominal cavity, the peritoneum? Whether the entry point is the side or the back, the big question is about potential internal organ damage within that cavity.
So the shared risk is peritoneal violation. Makes sense.
Exactly. And the last one is 2103, which covers the extremities, arms, and legs. So if you have that penetrating wound to the arm needing exploration to find the depth, that's a 2103 clear anatomical zones.
Okay, neck, chest, abdomen, flank, back, and extremity. Pretty clear.
But knowing the codes isn't enough. We absolutely have to talk about the boundaries. When can't you use these codes? There are basically two key situations.
Okay, the exclusion rules. Let's start with the first one. What if the work done is sort of, well, less than this deep exploration we've been talking about?
Right. That's boundary A. Doing too little for 2100, 2103. This is about when you should be using the standard repair codes instead of, simple, intermediate, or complex repair from the integumentary section.
So where's that line?
The line is that documented extension of dissection. If the repair doesn't require enlarging the wound significantly, doesn't require that active exploration deeper into muscle or fascia to find the extent of the injury, and doesn't involve hunting for a deep foreign body, then you can't use 2100, 2103.
So even if it's a stab wound penetrating trauma, if it's clearly superficial, doesn't seem to go past the subcutaneous fat, and the surgeon just cleans it and closes it.
Then you use a standard repair code, like 12031, 13153 range, depending on complexity and length. You can't bill, say, 2103 for an extremity just because it was a stab wound. The procedure performed has to match the code definition, including that need for deeper exploration. Documenting the necessity for that extension of dissection is key.
Got it. So boundary A is about not meeting the procedural requirements for exploration. What's boundary B? Doing too much.
Exactly. This is where the injury is more severe and requires major intervention. The definition for 2100, 2103 explicitly states they apply only if the procedure does not require a thoracotomy or a laparotomy.
Ah, okay. So thoracotomy is opening the chest cavity, laparotomy is opening the abdominal cavity.
Correct. So let's say you start exploring a chest wound thinking maybe 2101, but during that exploration you discover significant internal damage, maybe to the lung or a major vessel, and you realize you have to open the chest, fully perform a thoracotomy to fix it.
Then what happens to the 2101 code?
It gets dropped. The moment the procedure escalates to a definitive repair of a major structure or major blood vessel requiring that full cavity access, thoracotomy or laparotomy, the code for the major repair takes precedence. It supersedes the exploration code.
The exploration basically becomes part of the bigger operation.
Precisely. It's considered integral or incidental to the major life-saving procedure. You wouldn't bill 2101 in the thoracotomy with lung repair. You'd build a code for the thoracotomy with lung repair. Same logic applies to the abdomen with 2102 and laparotomy.
Can you give an example of a major structure repair?
Sure. If exploring an abdominal wound, initially maybe looking like a 2102, leads to finding and repairing a hole in the small bowel, that bowel repair requires a laparotomy and is a major procedure. The bowel repair code would be used, not 2102. Or repairing a major named artery like the femoral artery in the leg, that's a specific vascular repair code, not 2103 plus a vessel repair.
Okay, so that brings us back to the minor vessel ligation included in 2100, 2103. That really defines the limit. If the bleeding control stays within that minor scope in the wound track, you're still exploring under 2100, 2103. If it requires tackling a major vessel.
You've crossed boundary B, and you're in major surgery territory with different codes entirely. These 2100 codes are really for the assessment phase, the localized cleanup, figuring out if that bigger surgery is needed. They don't cover the big fix itself if it involves opening the chest or abdomen.
Right. So wrapping this up for everyone listening, what's the main takeaway? These codes, 2100 to 2103, they carve out a very specific niche for penetrating trauma. It's about surgical exploration, including things like debridement and minor bleeding control, specifically to find out how deep the injury goes.
Exactly. But it stops short if that deep exploration isn't needed. That's boundary A, use repair codes. And it gets superseded if a major repair needing chest or abdominal cavity access is needed. That's boundary B.
Understanding those boundaries and the required documentation, especially extension of dissection, seemed absolutely critical.
It really is. Connecting it to the bigger picture, these guidelines highlight how important it is for documentation to reflect the surgical intent. Was it assessment or definitive repair? And the actual depth explored. It's about accurately capturing that diagnostic versus therapeutic pathway in trauma.
Really clear. Thank you. So here's something for you to think about after we wrap up. We know these codes require that active surgical exploration, the extension of dissection. How might the decision to perform that deeper exploration and how it's documented differ depending on the type of penetrating trauma? Say, comparing a relatively clean stab wound versus the potentially much more disruptive path of a high-velocity gunshot wound. The physics of the injury might inherently change the clinical threshold for exploration, which then directly impacts coding. Something to consider.